Okay, I think the time now is just 2 minutes after half past 8. I think we are ready to start. Is this the improved clinical pathway services? Yes. Okay. But for the record, would you indicate to us what your names are and who's going to lead the discussion?
Repeat again.
No problem. Grant Rex, Chief Executive, ICPS, and I'll be leading the discussion.
And I'm Monica Springfield.
The way it works, I didn't get your drinks.
Okay.
So I'm Monica Springfield. I'm the Clinical Governance Lead for ICPS.
Okay. For communication to be easy, only one mic must be on at a time. So if you speak, the other one must have her mic off, just like we will do as well. Okay, very well. With that, are you ready to proceed?
Yes. They should have this system in Parliament so that only one person can speak at a time there. Right. What I thought we'd do is just present very quickly what my company is doing and what's been achieved, and then I think there'll be quite a few questions, so we'll probably we'll go through the slides fairly quickly and then just rather deal with the clarification questions and the cross questions after that. Okay, I'm not too sure. It's just like that. Right. The standardized care pathway is an attempt to create an evidence-based recipe, for want of a better word, for doing common procedures that are now routine. And it's used increasingly around the world to address costs and quality, so to try and improve quality or bring down costs while maintaining quality, or both. And often there is an opportunity to bring down costs and improve quality simultaneously, which is counterintuitive. It's not common sense, but it is quite often the case in healthcare that the better the surgeon, the quicker they are, the less the blood loss, the quicker the patient gets out of theatre and out of hospital, the cheaper the procedure and the better the result. So it is kind of a truism in particularly surgery that cost and quality move in opposite directions. This standardized care pathway is also known as second-level technology in that it is using management processes and looking at the whole pathway from diagnosis to discharge from the health service to re-engineer that, to re-look at that and look at ways of making improvements all the way along a pathway. So it is not about a new drug or a new bit of equipment or a new invention that's been patented. It's about the management of the process, that the intervention's taking place, and it is coming about largely because of the internet and the spread of information, so that best practice and the best ways of doing things is being spread much more quickly in the last 10 years around the world. So it's a new way of advancing healthcare in particular. Right, we started 3 years ago, quite small, and we decided to target the most expensive items that the medical aids are facing, which is hip and knee replacements. So it's the biggest single cost item because of both the fact that the unit cost is quite high and the volume of hip and knee replacements done is very high. So, it's always 1, 2, or 3 in the total spend of a medical aid. Just to give an idea. And we targeted that because we thought that we could produce the biggest benefit, both to the medical aid and hopefully to government hospitals at that stage. And that's in fact how it's turned out to be. So we started with, in fact, 3 surgeons who did pilot cases for us, and we then got another 3 surgeons involved in different centers around the country, and soon we got an interest from a medical aid that wasn't offering hip and knee replacements. It was just too expensive for them, and their members were forced to go to the government hospitals, which had 2 problems. Firstly, it was increasing the waiting list in government hospitals, and secondly, the waiting list was up to 8 years in some of those hospitals, so that these patients were often older, and they were dying before they got their hip or knee replacement. So it was a big problem for them, and they immediately decided to try our standardized pathway, which is now only being done by 6 surgeons in the country, fortunately 1 in all of the major centers. And that was Transmed, who are administered by Momentum. So it was quite a courageous sort of stance, given that we we'd done a very small pilot with Discovery of just a few cases, 20 odd cases. And however, we had brought the experience from the UK, where I was the managing director of Partnership Health Group, which did contracts for the NHS. So we did 20,000 hip and knee replacements over a 5-year period in the UK. And that's where we got the whole concept and got the ideas from, and decided to bring it back and translate it into the South African context. Since then, we've now, MedScheme embraced the process quite enthusiastically after we had done enough cases to prove the concept. So after about 200 cases, they signed up. Bonitas were the first to sign up, and subsequently we've got over a dozen medical aids involved, and essentially 45 surgeons are now participating, and we're in all 9 provinces, and it is going from strength to strength. We've done over 1,000 cases, and that's the breakdown: 68% knees and 32% hips. That's back. So. Let's go back one. Let me do it. Yeah, not doing that. Okay, next slide. Okay, so the things you're trying to tackle, the key cost drivers in the private healthcare context. The other thing worth noting is that we were selling, as a private company, making profit in the UK, hip and knee replacements to the NHS at that stage for about £5,500, and at that stage the rand was almost, it had gone almost down to 10 to the pound, so it was about 55,000 rand, and the reason this business became an opportunity was because the average price that the medical aids were paying at that stage in 2010 was about 100,000 rand. So we were doing it at half the price in the UK, where doctors generally earn more in government hospitals, and where the cost of things is certainly, and nurses earn a lot more than they do in South Africa. So your key cost drivers in the hospital context are much higher, in fact. And we were delivering it at half the price. So I just thought, there's got to be an opportunity here somewhere, and an important contribution to make to the South African healthcare environment. So the key cost drivers here in the private sector, as well as the government sector, are theatre time, length of stay, level of care, which refers to a normal ward, high care, or ICU. Your surgical consumable utilization, what is being used in the operation, your drug utilization, the clinician's costs, the anaesthetist, the surgeon, the physio, and then radiology and pathology costs. However, you can't just cut costs without thinking about the next block, which is quality. So any attempt in healthcare to cut costs, you have to start thinking about quality. And unfortunately, in South Africa, in the fee-for-service environment, there are no measurements of quality really being used to any great degree. It is virtually non-existent. And it's true all over the world. Until quite recently, it just wasn't on the agenda. In the government hospitals, it was just about getting the volume through. There was a little bit of quality control in government hospitals internationally, but not much in the private sector, which was a fee-for-service. And people just assumed the more they pay, the better the quality is going to be. There's just been an assumption. And so the whole value proposition has not been in healthcare internationally. And the reason is basically that quality is very difficult to measure. And just by way of illustrating that, your better surgeons, for example, might attract the more difficult cases, might get a reputation for being good, so they attract the more difficult cases, and therefore they may have more complications than a surgeon who's not as experienced or who's worse. So at a very simple level, it's a difficult problem to solve. However, since the advent of the internet, there is now so much information emerging and so much experience emerging around this, and it's such a key area for healthcare internationally that there are now a whole lot of quality measures that are increasingly well established. So patient-reported outcome measures, which are surveys of patients about how you're feeling before the operation and after, in terms of pain, mobility, your function, your ability to work, get around, drive a car, have a bath, blah, 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 blah. So it's a common sense way, but it's generally regarded as a pretty good start to establish, is the operation making a difference and is it positive? One of the ones that is used in the case of joint replacements, major joint replacements like hip and knees, is the WOMAC score, which is the Western Ontario and Mcmaster orthopedic assessment. It's internationally accepted, and it's been assessed and found to be a reliable measurement tool. The other concept that's emerged is that there are established ways of doing procedures. So, for example, if a patient has been on anti-inflammatories and has had a bleeding ulcer and has got low hemoglobin, the oxygen-carrying part of the blood, they're called anemic, and you should not operate on an anemic patient in a planned operation. You should get their hemoglobin to the right level and then do the operation. So there are a set of rules, there are a set of agreed standards that you should use that go up towards making a pathway, a standardized care pathway. However, particularly in the private sector, where independence of practitioners is highly cherished, and a lot of the private sector attracts doctors who like the independence and like to have the freedom of their own practice. There's a lot of resistance to this idea of a standardized pathway. However, the scientific case for it is now so strong and so certainly at a higher level, no one can argue with it any longer. And yet it's not being used at all. And it was not being used at all in the South African context until we introduced it here 3 years ago. And so one of our quality indicators is compliance with the pathway. So we monitor hospital bills and just get an assessment of whether the team, the surgeon, the anaesthetist, the physio are sticking to the guideline. They might sign up to it, but they might not be using it. So we monitor compliance to the pathway. And the pathway is evidence-based. And it's updated regularly by very experienced professionals and clinicians. So, and as well as by the whole network, if they become aware of new evidence emerging that's published in the scientific journals, they let us know, and we update our protocols continuously, essentially. So adherence is a key quality indicator. And then a very small thing is really in the private sector, it is unusual for anaesthetists to see a patient before the operation. And by before, I mean, 2, 3 or 4 weeks before, in order to give time to optimize that patient for the operation. So if they are anemic, or if their diabetes is uncontrolled, or their blood pressure is uncontrolled, they should be sorting that out before the operation, not after a massive insult or assault on the body, and then try and sort it out post-operatively. The vast majority of planned elective surgery in South Africa, the anaesthetist sees the patient on the red line, which is as the patient's being wheeled into the theatre for the operation. And there's no time to optimize them. And that is causing, in our view, a much higher complication rate and driving one of the big cost drivers in the system currently. So we've just insisted on what is, no one can deny that this is an established scientific and clinical practice all over the world, including in government hospitals in South Africa. The patient must be assessed by an anaesthetist with enough time to sort out or postpone the operation in order to sort out the things that can be sorted out. So that is a big change that we've made in the private practice in this network. And the other big thing we're doing is we're monitoring adverse incident report. We're doing adverse incident reporting. We're monitoring adverse incidents. So there's a categorization which I'll ask Dr. Springfield to take you through just now. And essentially, if a patient has a heart attack, or if the patient slips and dislocates their hip within the first 30 days of the operation, or the first 90 days, you should be recording that and giving the feedback to the surgeons and getting a bit of peer review going, do root cause analysis, get them to understand why are these problems happening. And so that's a very critical part of improving quality, continuous quality improvement. Of course, it happens in government hospitals, generally speaking. They do case review and they do review of x-rays after the operation, for example, as a team. And then they learn from the mistakes that they see, and it's called peer review. Non-existent in the private sector in South Africa. So people have no idea how good or bad they are. There's no measurement of outcomes. They have no idea how good or bad they are. And I mean, it's shocking, but that's the situation. So none of these innovations are rocket science. They're things that McDonald's burgers or would have introduced 30 years ago, But healthcare is, really very resistant for the structural reasons that I'm sure you're quite familiar with by now.
Go back 2 slides, please.
Which is the reverse? Eh?
Can we go back 2 slides, please?
Okay.
There we go.
Okay, now go forward 1. Okay, so the first innovation is that we're getting the pre-operative assessment. At the moment, 87% are being done by anaesthetists, which we also regard as a clinical quality indicator, because the anaesthetist is best placed to judge the risk of that patient for an anesthetic. And it's quite good if the anaesthetist sees the patient post-op as well, to just see that the type of anesthetic they gave, what the consequences were for the patient with that profile. Where in parts of the country where there aren't enough anaesthetists and they just don't have time to do the pre-op assessment, we get a physician to do it. But in 100% of cases going through our pathway, patients are being pre-assessed and they're being optimized for the operation. And it's we regard this as a significant innovation, that 87% of them are being seen by anaesthetists, actually. And we're seeing results from that, which we'll show you now. Next slide. Yes.
Now, how long, when should this pre-operative assessment be done? How long before the actual operation?
So ideally, it should be done to give the patients enough time to be optimized. We, in our pathway, we ask that the anaesthetist or that the pre-operative assessment happens at least 2 to 4 weeks pre-operatively. So we feel the surgery is elective surgery. There's never a reason why it needs to be rushed, and never a reason why it needs to be done on an unoptimized patient. So we have in our pathway that these patients be seen 2 to 4 weeks to be optimized, and then we have a second person reviewing that optimization and reviewing that assessment.
I can understand in an emergency a situation where it has to be done now, something that was never foreseen. But where, the specialist knows that in about 4 weeks' time, you'd be undergoing an operation. That's the case that you're talking about.
Yes, so these patients have been walking around with their wonky hips and knees for a while. It's never an emergency. So there should always be enough time to make sure that the patient is in the best possible condition to have the best possible outcomes of the surgery. And that is why there's never pressure to do a patient urgently on our program.
You get a phone call from a nursing sister saying, don't eat after 10 o'clock in the evening. That's it. Now, do doctors know about this?
Do they know about the pathway, or do they know about pre-op assessment of a patient?
About the need for pre-operative assessment.
It's well evidenced, and it's best practice. Internationally, it's a best practice, particularly in these patients. There are very, very few, around about 10 to 12% of these patients have got no other medical problems and are fit and healthy. So it's a very small percentage. And the majority of these patients are older than 60. So that puts them in a category that inevitably they will have a health problem, or they will be on medication for other health issues. So they need to be seen. So it's well documented, and it's well evidenced, and it's best practice. And internationally it happens. Unfortunately, in the South African context, for varied reasons, this doesn't happen. So patients are seen on the day of surgery, or on the red line just before theatre, or they are admitted the night before at the cost to medical funders, just to be seen by the anaesthetist. And even then, it's still too late. The day before, can still be too late, because to optimize a patient then. And also the patient is then prepared for the operation. They're prepared, they've taken time off work, as you say, they've starved, they're lying there waiting to be done, and then to be seen on the day of surgery and not getting proper informed consent, because I don't really believe that informed consent can happen on the day of surgery.
It probably is too late when the theatre room is already prepared and everyone is ready to cut you. Now, but why do doctors do this? If they know that this has to be done, why do they do it? Is it because they don't care? Or is it because they don't taught these things at school? Why do they do it?
Look, there are structural reasons. In the case of anaesthetists, the vast majority are single-person practices. They are in theatre from 7 a.m. or earlier until 7 p.m. or later, 5 or 6 days a week. And that's where their revenue comes from. The medical aids don't pay for operative pre-assessment. So for them to put aside a morning to do pre-op assessment clinics is just not financially viable. So there are structural problems. One of the reasons why it's done uniformly in the UK in a system like the NHS is that the anaesthetists are employed, so they get allocated to do an operative pre-assessment clinic. Everyone knows this in South Africa. Everyone knows that that's the gold standard, and that's the correct standard. And I mean, there are places where it's done. So there's a big group practice, interestingly enough, in Durban called Beck Danchin and Associates, who do operative pre-assessments and have done it for 10 years. because they know it's the right thing to do, and because they're a practice of 30 plus anaesthetists, they can allocate their members to do this sort of thing. But there are real problems establishing group practices in South Africa. It is, there are so many regulations pertaining to shared income, and firstly, employing doctors, everyone feels is pretty much impossible, that it's basically illegal. A lot of doctors would be prepared to be employed and therefore be used more correct, be able to practice better medicine. But it's simply, it's a very difficult thing to do. There are a few mine hospitals that have employed doctors, and obviously the government hospitals, but in the private practice, it's really regarded as impossible to do. So there's a big structural problem. And then the other structural problem we're going to touch on, which is where you have a different alternative reimbursement mechanism, payment mechanism for doctors, where you can get them you can incentivize them to take quality into account, and that there also are difficulties with the regulations, which we'll take you through.
Sorry. Does it all come down to money?
The irony is that anaesthetists have said, look, we're not paid extra for a consultation. Our remuneration is based on time units, and that is when the patient gets clocked in to go to theatre, and when the patient gets clocked out, that's the time that the anaesthetist gets remunerated for. And so there are no time units for a pre-operative assessment. However, when anaesthetists bill for this, medical aids there is a code for a pre-operative assessment, so anaesthetists do get paid for doing a pre-op assessment. It's not time-based, it's just a code called pre-operative assessment, and then there's remuneration attached to that. So there is remuneration for it, but anaesthetists feel that that's the assessment that when they see the patient pre-operatively on the red line, that gives them enough time to assess the patient. I personally don't think there is enough time.
I think we must be, keep in mind that the optimization is the important part here. So in other words, seeing the patient and assessing them is one thing. And I guess most anaesthetists in South Africa could claim that they are assessing the patient. But if it's being done a half an hour before the procedure, or the day before, or the morning of the operation, there's no time, realistically, in most cases, to do the necessary optimization. So going back to your, how much time is required, we just, as a guideline, suggest to the surgeons, don't book the patient sooner than 2 weeks from the anesthetic pre-assessment, because you might need time. And you can't build up the patient's expectations and then delay them. It's tough on them psychologically. So the key thing is you just need to give yourself enough time. And in fact, we don't authorize the operation until the patient is optimized. So in fact, we give ourselves an infinite amount of time. We just say don't book it sooner than 2 weeks. But they have to get authorization, and to get the authorization from us, we require the hemoglobin, the proof that the diabetes is well controlled, the blood pressure, a whole lot of things, measurements that we use to ensure that the patient is at least nominally optimized, for the procedure. And that means, that if they're struggling to get the diabetes sorted out, they can just delay the operation until it's sorted out, and they explain to the patient, because they've seen them at a pre-op assessment clinic, and they've got the time then to sit and actually have a proper discussion and so on. So it's a very small change, but it has a massive difference, as we'll demonstrate.
Sorry, can you when you introduced yourselves, you told us your names, but could you just tell us a little, why do you know this stuff? Can you give us a little bit of your training background and what you are?
So I'm a South African VITS trained anaesthetist. I did my training largely at Baragwanath Hospital. And then I moved down to Durban, and there I joined a private practice, Beck and Danshan, which was unique in that it was the biggest practice in South Africa. We had 57 anaesthetists, and the support that came from being in such a large group. I then moved to the UK, and there I got involved. I first worked in the NHS, and I got a substantive post in the NHS, which meant that I could be employed as a consultant in the NHS. And then I started doing work for Care UK, PHG and Care UK. It was a company that formed a joint venture with Life Healthcare, and they developed clinics which provided treatment for NHS patients, but in a private setting. So the management structure was private, but it was NHS patients, so it wasn't fee-for-service. The government, instead of paying NHS to do the patients, they paid Care UK to do the patients. So I started doing a lot of development work for them, developing policies, setting up programs to do. They were given a small basket of surgery like hip and knee replacements, cataracts. So I was I developed pathways for this independent treatment sector. It was called, and there were about 10 hospitals nationally, and out of that, 2,000 cases were done over a 5-year period of just hip and knee replacement surgery. And we started playing around, reading the latest literature, and started developing this pathway. So the pathway slowly happened over a 5-year period, evidence-based. The UK at that time started looking at standardized care pathways, which was first started for surgery on the abdomen, like on the abdomen, where they showed that if patients are done in a certain way and optimized, and if a pathway gets followed and measured, that the outcomes, the adverse event rate afterwards are a lot lower, and the patient has a better quality outcome. And then they started doing it in Europe and in the UK. They started doing it on hip and knee replacement surgery. And because I've been involved, anesthetizing myself, developing pre-operative assessment clinics. When I relocated back to the UK, a Grant worked in the UK. He was the medical director of Care UK, and together we came back and we put this process in place in South Africa. So that's my background.
I'm also qualified as a doctor, but practiced very briefly at Alexandra Health Centre at a time in the early 90s when there were very experienced managers who had worked in the UK and were trying to develop cost-effective care and making sure that the quality was retained, even though the resources were there were very few resources in that environment. So the whole concept of cost-effective medicine while retaining quality was what that whole organization was about. And the whole notion of unit-based costing was well established, quite uniquely in that environment, where they were trying to assess what does it cost to treat a pneumonia or a middle ear infection of a child, and they were coding conditions and trying to establish the costing down to unit-based level. Not very successfully, because they weren't doing itemized billing, or they weren't capturing costs in an itemized way. So I then worked as a superintendent at Baragwanath Hospital for a couple of years and got an insight into how, when you employ doctors, what you can achieve if they're correctly motivated. And in those cases, it wasn't monetary incentive. It was really just appealing to their morality and their scientific excellence, their academic excellence. And then I moved on to the private sector, where I was exposed to fee-for-service billing, which has an important strength, namely that you can track costs in a lot of detail. Every single thing used is captured on a system. And that allows you to be able to develop unit-based costing, which is lacking in the government services. So, that background gave me, and then of course I was involved as the managing director, not the medical director, of Partnership Health Group and then Care UK Secondary Care, where again we employed the doctors and were able to try out a lot of things to improve quality and control costs. Right, the second innovation I think we've dealt with, so I think we can... the important thing to note here is the introduction of the American Society of Anesthesia's assessment scoring. They've got a standard scoring system for assessing the risk of a patient pre-operatively, or for assessing a patient. And that is an indicator of the risk that patient poses in an operation, the risk of complications and that sort of thing. So that is a system that we're using to score all the patients, and that's quite innovative. I'll let Monica add a little bit to that.
So we have we call it a minimum data set of data that we require from the doctor when he registers the patient onto the ICPS pathway. And so we look at we'd like an assessment of the patient. We look at x-rays and part of the assessment, and then we also, there's some blood tests that we require. So we have a look, and we have an inclusion and exclusion criteria that it's a line in the sand that the patient is scored and assessed against. So we look at things like Grant said, the patient's hemoglobin, and there's lots of evidence to show that a low hemoglobin predisposes the patient post-operatively to complications. If it's a frail granny and now she doesn't have enough oxygen carrying capacity, her heart might struggle and then she would develop a heart attack. So we look at the patient's hemoglobin, we look at the patient's kidney function. We make sure that we look at some parameters to make sure that their diabetes is under control. And then part of this is this ASA categorization, where we have the anaesthetist scoring the patient. If there's a GP or a physician involved, they know about the scoring system, but we also have an independent sort of clinical committee that looks at every single assessment together with the blood results and comes up with a scoring system of the patient. Because anaesthetists, even when they do see the patient, may not see the patient with their blood results. So we're in the unique position to get the blood results plus the assessment and come to a conclusion of the patient's ASA score. And we do have a cutoff that we'll see ASA patients 1 to 3. So that is, ASA 1 is they're fit and healthy and they don't have any diseases. ASA 2 is they do have a disease, but it's well controlled. Like, for example, high blood pressure, but it's well controlled. And then ASA 3, there are two categories, those with now they have long-standing diseases and they have other organs that are being affected because of that. So if a patient's got high blood pressure, they begin to put a strain on their kidneys, and their kidneys begin to slowly dysfunction. So we look at that grade of kidney dysfunction. So ASA 3 is they have what we call end organ dysfunction, but it's still controlled. And then ASA 4 is when the organs are so damaged that now it begins to fail. So that's just degrees of how compromised the patient is. So we will operate and grant authorization on patients ASA 1 to ASA 3. From ASA 3, they got to be sent back. They got to be investigated because a lot of these things are missed. It's got to be investigated and it's got to be managed. And we've had very good results from having that line in the sand. Next slide, please.
This is just showing that the majority of our patients are in the ASA2 category, so they're well controlled, but there are 14% who are in the uncontrolled category and need to be optimized, and that I think is where we are making a difference to that group of 14%. Next slide.
You don't have SA4.
So, like I said, in our criteria, our inclusion criteria, it's ASA 1 to ASA 3. And ASA 3 is that it is a patient with comorbidities, they've got long-standing disease, they do have some end organ dysfunction, but it is still under control. They're well controlled for the disease, but they do have some of the end organs affected, but it is not compromising the patient. So, and then ASA4 is when they, like I said, they're quite ill and they have unstable disease, or the end organ function is bordering on failure and it needs to be managed. So we do not operate on ASA4 cases. Doesn't mean that they excluded from the program, it just means that they optimize. So they do, once the hypertension is under control and the diabetes is sorted out and they've been taken off drugs that are damaging to the kidney, this patient, the parameters do improve, and then they move from an ASA4 to an ASA3 to withstand the surgery and have good outcomes after the surgery.
And so the categories that you've just mentioned are the ones that is up to 3, are the ones on which you can operate. Is that?
Yeah, you shouldn't operate on patients ASA4. The risk of dying is quite high. So, the aim is really a lot of patients really just aren't fit enough for a hip or knee replacement, but, it's seldom the case that,
require some kind of attention before they can get into the theater. Is that how it works?
Can we just repeat that again?
Maybe I am misunderstanding what the whole process is about. Now, I thought that this is about a pre-operative assessment, right? Now, 1, 2, 3, as I understand it, are the ones that can be operated upon. Is that right?
Yes.
Then 4 is the category that cannot be immediately, because they require attention before they can be ready for an operation.
Yes, so all patients on the assessment, we're just showing with that slide, is that the majority of our patients have 1 or 2 more diseases other than just the osteoarthritis or the problems with the hip or knee. So they have medical problems that need to be seen to. And even in, so we will only operate on ASA1 to ASA3, and the definition of that category, that these patients have diseases, but it is optimized enough for them to have surgery. So in ASA4, that patient is not optimized. By definition, they have uncontrolled disease that needs to be managed. They are uncontrolled diabetic, not on medication or not enough medication, and they need to be put on medication and then stabilized for 3 to 6 months before we accept them back onto the program.
Okay, next slide. Okay, the third innovation we've really discussed already. That's the WOMAC score, which I think is worth noting. Next slide. So this is the outcomes of our WOMAC scores. Okay, Monica will just take you through that.
So what is unique to our program as Grant said, is the fact that we do patient-reported outcomes. So this is a self-reporting measure where patient reports on their level of pain, their level of stiffness, and their level of function around climbing stairs, putting on socks, walking, getting up from a chair. So it's done independently by the physiotherapist, which sees the patient pre-operatively. It's also another unique thing that we do, is that we have a physiotherapist assessing the patient pre-operatively to assess their level of pain, stiffness, and function, and then does a lot of education with them, and does this WOMAC score. The physiotherapist sees the patient in hospital, and they do exercises and rehabilitation, and then post-operatively there's another visit, which happens in that 3 months, where the physiotherapist does another WOMAC score. So this is all done by the physiotherapist. At 6 months to a year, we have an independent person. So it's blinded to who the surgeon was or who the physiotherapist was. They just call the patient, and they take them through the scoring system, and then the patient scores post-operatively the patient's pain, stiffness, and function again. So this is and we collect this data. So this is the pre-operative scores. The range is as low as 16. It's out of a percentage. It's as low as 16. And we've had patients who've had pre-op scores of 86. The good thing, the important thing about doing this as well is that the X-ray may look really bad. Okay, and everybody says never operate on an X-ray. So you have to look at the X-ray, because some patients have really bad features on X-ray. The joint looks completely destroyed, but they're motivated and they have higher pain thresholds, and they're able to do a lot more despite that X-ray looking really bad. Or you may have patients with hardly many changes on an X-ray, but the tolerance is a lot lower, so they complain a lot more of pain and stiffness, and they find that a lot more debilitating. So with us having both these measures, it gives us a better sense that there's not really an over-servicing by the surgeons, that the patients are getting the operation because they need it. And so we do this pre-op and post-op scores, that's the range. And then we've also looked at it between hips and knees, pre-op and post-op. So every single patient has a scoring that gets done.
And as you can see from that, the post-op score is much higher than the pre-op. So the operations are making a big difference to these patients as reported by the patients. Any questions about this score?
I think you can proceed.
Next slide. That's okay. So the fourth one is that we have a formulary. So there are currently 30 plus suppliers of joints in South Africa. And, you know, a hip joint is fairly similar from, you know, they've been around for the last 40 years. Everyone's established more or less what the parameters are. So often there's not much difference between these products. And we're able to limit it essentially to 4 of our main suppliers. We managed to limit it essentially to those from the 30 plus suppliers. And as you can see, about 6 of them do most of it, and 4 of them supply most of the joints. So you're able to start negotiating a volume-based discount, which can also be quite significant. Because of being able to direct surgeons to a limited range. The criteria for being on the list are, being on a joint register elsewhere in the world that is respected, and having acceptable survival rates over a 10-year period or longer. And they also need to be registered on the, with the Europeans or the Americans, and essentially they need a CE mark, what's called a CE marking, which is an indicator of quality. So there's no compromise on the type of prosthesis used. Even though you're able to standardize it and bring the cost down, you ensure that there are criteria to maintain the quality for the prosthesis that's used. And as you can see, we're using reputable suppliers with massive international companies with good track records. Next slide. Okay, we've discussed the clinical, the guideline adherence. I don't think I'm going to go into more detail unless you're interested in anything there.
Okay, so we have a guideline. It's not imposed on anyone. The clinician still sees the patient, and it's the clinician's prerogative to do what they feel needs to be done. So we just have a guideline that is evidence-based, and it's based on best practice both in the UK, South Africa, the UK, the States, Australia, Denmark. So wherever they are big orthopedic registries, we've looked at their practices, and it's well evidenced in the literature as well. So based on the evidence out there, we've drawn up a guideline. We have also gotten the buy-in of our anaesthetists and doctors who use it. We fly the guideline past them, and because South African practice might be slightly different, so we make sure that it is in line with the South African practice. And so the guidelines are there, and all we require is that if the practice is different to our guidelines, they have to provide evidence as to why they're using that, and we have a discussion around it.
Next slide. Right, now the crux of the matter is that the outcome measures that we use are length of stay, and ours has dropped, the average in the industry, 6.9 days for an uncomplicated primary joint replacement. We've got that down to 3.8 days. That is much less a cost-cutting objective than it is a measure of quality. The patients are not forced out of the hospital, they only go when they're ready to go, and when they can prove that they can get to the toilet unassisted and walk upstairs unassisted, and bend their knee sufficiently to perform their daily functions, or their hip. And so that's an indication of quality, that our patients are getting to that point quicker than the average. High care utilization is also another quality measure, because patients should really only go to high care when they're sick.
Can we just go back to this? How do you know? How do you tell that, but for your intervention, the patient would have stayed longer?
Generally, the surgeons who join the network, their length of stay is reduced after joining the network. And often, some of the surgeons in our network are using the pathway only for the ICPS contracted patients. And the length of stay is shorter for those patients than for other patients, not where they're not using the pathway.
How do you know that, but for your intervention, this particular patient would have stayed longer?
Well, if they're not optimized, they will stay longer. So what has been happening is, because patients are seen before on the red line or on the day of surgery or the day before, and they're not optimized, inevitably they have disease processes that needs to be controlled. So these patients inevitably then go to high care or go into ICU. And we've shown that when that happens, there's ICU and high care patients are treated in a very similar way. They all get urinary catheters, because if you're going to measure, how you're going to measure without putting in a urinary catheter. And then they have drips put in, and they have intravenous medication, and they're not getting up, and they're not mobilizing. So the result of that is that there tends to be a higher adverse event rate. Patients get confused, they develop a deep vein thrombosis because they're not moving, and their length of stay then increases. So we've shown that it wasn't dictating into anybody. We just said, start with pre-optimizing your patient, and then let's have a look at the outcomes. And start with active rehabilitation. So instead of that patient lying there post-operatively being completely zonked out on medication, feeling nauseous, not moving for at least a day or two, then start moving, then start exercising. It increases that length of stay. So our patients are well optimized, are hydrated. The anesthetic is in a particular way, is done in a particular way. Post-operatively, these patients are sent back to the ward. They're eating and drinking within an hour of the surgery. They're getting up within 4 to 6 hours after the surgery. So that means that they begin to rehabilitate on the day of surgery instead of traditionally 2 days post-operatively. So by the time they are reaching the milestones, which is a set criteria that they have to be able to bend their knee to 90 degrees, because that means they can sit in a chair and get out of a chair. They have to be able to climb stairs and so on. By the time they reach those milestones sooner than a patient who's been lying around for 2 days. And then the other important thing that we do is we do what's called discharge planning. So we plan beforehand, and this is the role of the physiotherapist, to make sure that that patient is able to be discharged. So they look at the patient's home circumstances. Will the patient have care? What's the patient's ability to rehabilitate in this quick fashion? And will there be someone to look after them, or do they need to go into an aftercare facility for a day or 2 or 3 just to help them along? Because what happens is patients are now in hospital, they get their rehabilitation, and then it's discovered that, well, they don't really have anybody to look after them at home. So they can't go home on their own. And now they have to go to an aftercare facility. That takes a week to organize. So the patient's length of stay, instead of being 3 days, is now 5 days without needing the post-operative care facility, and then to try and organize that another 5 days. And that is why you have length of stays that can go up to 14 days, unnecessarily, with a patient waiting to go into a post-operative care facility. So that is what we try and avoid. We plan for discharge pre-operatively. So we say to the patient, look, you got to have, is there someone to take care of you? Your daughter who lives a distance away has got to come and live with you, or that kind of thing.
I fully understand how it operates, but what is not clear to me is how can you tell that but for your intervention, Ngobo would have stayed longer in hospital?
Look, this is based on over 1,000 cases, and the data we're comparing it to is on many, many thousands of cases. So it's a statistically valid set of figures, that we can, subject to various statistical things that show that our program is differentiated on these measures. So, the chances of a patient ending up with a lower length of stay, not needing intensive or high care, is much higher coming through this side than going the normal way. That's really the way of looking at it, I think.
And let me just add as well, what's unique to our program is that we, as an independent body, has a relationship with the funders. So patients, if they have a complication, the tendency, particularly in South Africa, is that they don't go back to their doctor who they perceive as messed up. They go to someone else. But it's still the same medical funder. So the medical funder will have information that this patient didn't go back to that surgeon. So his stats may look good, but the patient has gone back to someone else because of the surgery. So we, at 3 months, and we get the stats every 6 months. We sit down with the funders and we get those stats, the 30-day and 90-day readmission rates. And we have a look to see why did that patient come back to the same surgeon, to another physician perhaps, and could it have been related to that surgery? And then we manage the patient along. So in that patient's key performance indicator would be, well, actually your 30-day readmission rate's quite high, or your 90-day readmission rate's significant, and what is happening in your practice that allows this to happen.
Okay. The high care utilization and ICU utilization are also indicators of the fact that the patients are doing better post-operatively and don't need those levels of care. So, any questions around that?
Same question that I have in relation to the others, because it does seem to me that is it perhaps based on the assumption that because you've gone through this process, therefore your stay is shorter because of the process? Let's say you go through the process, you stay 14 days, the assumption would be that but for the process, you would have stayed 20 days. Is that how it works?
Look, the pathway is an attempt to improve quality and reduce cost. Fortunately, those things are not in conflict with each other. So the quicker the patient recovers, the better the quality by definition, and the lower the cost. There are a lot of technical things we haven't gone into in the pathway. So there's a lot of detail on the anesthetic, the correct sort of anesthetic to use for different kinds of patients, the preparation pre-operatively and post-operatively. There's a lot of detail that goes into producing these results. That is really in the pathway where we've given you the headlines in previous slides. So, it is, I guess you can say, an assumption, but it's got a lot of statistical sort of strength in the evidence that's emerging now. And it's replicable. We've done it not in 2,000 cases in the UK, in 20,000 cases. Same pattern, where their average length of stay was in fact 7.3 days, and ours was 3.9 days. So quite similar in that context, using the same pathway essentially, slightly modified for here. So increasingly, it's clear that the pathway is the thing that's making the difference. If it was successful in the UK and here, producing the same results, then you can assume, our assumption is fairly strong, I think. It's fairly strongly evidenced. Okay. This is really the most important slide, and I'm going to let Monica just take you through it briefly, but I think we should really just focus on questions for clarification. And maybe that's where we should start. What have you got any questions about this slide? I mean, broadly speaking, we've got three groups there. The ICPS is the grey. Various funders that we deal with are the orange, and then we've got a particular study that was published of 1,300 cases over the last it was about 4 years ago, done by MSO, who are one of the administrators in healthcare in South Africa. So the adverse incident event rate or complication rate are categorized into using the Medicare definition from the United States, and there are three categories, 1, 2, and 3. And then we put those in those three columns, type 1, type 2, and type 3. As you can see, the total ICPS adverse event rate is 5.7%, versus the industry average of 23%, the industry rate of 23% on average, and in the MSO study of 17.6%. That was for a cohort of 1,300 patients in their population. And then the categories are broken down further.
Is there a difference between complications arising from a pre-existing condition which was not identified prior to the operation and a complication arising from the operation itself?
Okay, so that's why we have those three categories. In category 1, we try to address the non-surgery related adverse events. So it is whether it's as a result of the anesthetic or as a result of the patient's underlying condition. So if the patient has uncontrolled hypertension and or uncontrolled anemia, and now they get a heart attack because of that, that will fall in category 1. And those complications usually happen quite acutely. It happens in that first 7 days of surgery, 7 days post-surgery or in the length of stay that happens. And then category 2 and 3 looks mainly just at the surgery and the surgeon. And we've divided that into minor and major events. So a minor event would be bleeding. It's not necessarily a complication that the patient bleeds, because it's a recognized side effect or effect of the surgery, but it's the amount of bleeding that happens that if it is now compromising the patient and the patient now needs a blood transfusion, that's the measure that we look at. Or they may just get a skin infection. So this is what we consider minor adverse events related directly to the surgery. So were it not for the surgery, they wouldn't have bled or they wouldn't have got the infection. And then category 3 is more serious or major results as a result of the surgery. So it's like deep wound infections or dislocations.
To the question, is there a distinction between the two? Well, you see, it seems to me that this process can be very helpful in eliminating the complication which can arise from a pre-existing conditions, because you can identify them before and address them. Am I correct in that assumption?
Yes, and I think that's shown in the type 1 complication differential. Type 2 and 3 is probably more just related to the surgical expertise. And there we have criteria for admission of surgeons onto the network. So it's generally accepted that at the moment, training of orthopedic surgeons in joint replacement is decreasing in government hospitals, and often newly qualified orthopedic surgeons are doing a fellowship in joint replacement. There's also a lot of literature to show that you have to do a certain number of operations a year in order to reduce your complication rate, and there's plenty of published data on that internationally. So we use a criteria related to essentially the Johns Hopkins criteria of a minimum of 25 knees and or 25 hips as a cutoff that you should be doing to be admitted to the network, or having, and in addition, having done a fellowship or being qualified for 5 years. And that is something we'll be discussing with the Orthopedic Association later today, actually. To try and get some buy-in to what, and guidance from them, in fact, around what the criteria, whether these are appropriate for the South African context. But it seems to be helping us in the type 2 and 3 complications, although we do think our pathway contributes a bit to those in that we are preparing the patient physically, pre-operatively as well, through a physiotherapist, strengthening For example, the non-operated leg. So that when the patient is mobilized and are standing on a strengthened non-operated leg, they're less likely to fall, potentially. And that might be coming through in the type 2 and 3 as well.
So there can be a situation where the patient has an undisclosed medical condition for whatever reasons that may then become quite obvious post-operatively. There's not much we can do about that other than sort of sitting and developing that relationship with the patient that, you need to tell us for your own good that you have this. But if you...
What you do after the operation is what would be critical in identifying some of those issues, is it?
So if there's a pre-existing condition that hasn't been divulged and then becomes quite obvious afterwards, obviously it has to be managed. But what we do is, there's a whole trend analysis as well, because we recognize that not everybody is exactly the same and that one patient may respond differently. So there's a whole, so the surgeon gets presented his stats. And if it begins to show that routinely these patients have a longer length of stay, and the reason why they have a longer length of stay is because they've had undisclosed diseases or disease processes that weren't managed or weren't obvious pre-operatively, then we're able to go back to that surgeon and look at his anesthetist, look at the physician he's using, look at his cohorts of patients as to why that is happening. So it's on the trend as well. These surgeons will pop out very quickly that there's an issue. And as an example, there was one surgeon that we used who had a high incidence of post-operative infections, and which meant that we went down to that hospital to have a look at their processes to see why is it that was happening. Is the surgeon, what's happening in theater, the antibiotic that they're using or not using, and so on. So, because we're collecting our data on so many patients from so many surgeons, we're able to then identify these patients. These patients pop up very quickly that something's going on in that system.
And just on a point of clarification, just to help clarify, the idea that patients are not disclosing everything to their doctors is purely a theoretical illustration by Dr. Sprinkle. It hasn't been an issue in our experience. So that's not a real life problem. The real life problems are slips and falls causing dislocations, post-op infection rates. Yeah, that's about it. Those are the main post-op complications that we experience in our cohort. Yeah, that would be unexpected and potentially avoidable. Okay, next slide. So the key issues that are confronting us are actually really the commercial and regulatory issues around the commercial issues. So the model that we've used pays the surgeons a fixed fee for the procedure compared to the current practice, which is that they have multiple coding for a procedure. And the reason we've opted for a fixed fee is that increasingly, if you've optimized the patient, the procedure is generally routine and similar. So the skin-to-skin time varies remarkably little from one surgeon to another, and the theatre time varies remarkably little. Really, for a routine primary joint replacement, there's no reason why you should have a surgeon bill double another surgeon's bill or triple when the outcomes are basically the same, starting off with the same type of patient. So that is generally accepted. That is completely embraced by the surgeons participating in the network. But there is ambiguity in the regulations, the Health Professions Council regulations. Ambiguity might not be the right word, but there is a little complication around it, and it is in relation to fee sharing which is part of the ethical rules of the Health Professions Council, and it is section 7.4. And basically that says that a clinician may not share their fees with another person unless they're a clinician and they played a commensurate part in the procedure. So the problem that we get confronted, or the challenge we get confronted with by the professional associations, both the Orthopedic and the Anesthetic Society, is that in some way this fixed global fee that we are being paid by the medical aids and then distributing in a fixed way to the various providers is in breach of fee sharing. Now, we've had legal input by Weber Wenzel on this. They feel that's a complete misreading of the regulation, and it's being read out of context. That we are not, the regulation was drawn up in order to prevent, let's say, touts like ambulances bringing patients to a hospital, and then sharing the surgeon's fee, getting a commission from the surgeon. It had that in mind. It didn't have in mind where, in other words, the transaction is between the clinician and the person getting a commission. It is clearly problematic from an ethical point of view. The model we've got is where the medical aid is our customer, and we are there to try and drive down costs and improve quality, and that's the primary contract. And we then negotiate the fees up front with the surgeons. They're not forced to accept them. It's negotiated on an individual basis. And essentially, there's no deduction from that, regardless of the outcomes. So they get their fee for doing the procedure. So does the anaesthetist. That is definitely not what is envisaged in the regulation, but there is a need for some clarity because it is being read. We're being challenged on this, and we have been for 3 years, and the challenges have been severe and very threatening. And there have been problems. Surgeons and anaesthetists are scared to join the network because they've been written to by their respective associations, and it has made it difficult to expand the network in that environment. Although it has been signed off by the legal teams in all the major medical aid administrators, we're very comfortable that it's not in breach. It has, nevertheless, there is this problem that I think we could do with some clarity on that. And I think the regulation doesn't conceive of an organization playing the role we're playing. It was just not imagined when the regulations, those ethical guidelines were formed. So it needs to be updated to take into account standardized care pathways, alternative reimbursement mechanisms that are necessary to reward quality and control costs. Any questions?
It's all clear.
Sorry, can I just clarify, is the physiotherapist fee included in that global fee as well?
Yes, but we pay them on a fee-for-service basis, essentially. So they get paid for the number of times that they see the patient, because we require them to see the patient more often. Firstly, we require them to see the patient pre-operatively, which is unique to our program. And secondly, we require them to see the patient twice a day while in hospital to increase the mobilization, which has got an important clinical quality contribution, because the quicker you mobilize a patient, the lower their deep vein thrombosis rate and the lower the pulmonary embolism rate, which is a very serious risk in joint replacement. And so rapid mobilization coincides completely with a reduction in serious complications. And the physios play a key role in that and are part of this multidisciplinary team, and they're part of that global fee as a result.
And do you know where it comes from in the patient's medical aid? So in some medical aids, there's a savings account and then there's a risk-sharing component. Do you know where in the medical aid they take the money out of?
Yes. The global fixed fee that we negotiate with the medical aids comes out of the hospital spend. It doesn't come out of savings or any of those other categories where the patient may need it for dentistry or for, over-the-counter medications or whatever. So day-to-day spending, it doesn't come out of. And that is quite unusual. I mean, the pre-op and the post-op physio we include in our global fee, and it's another incentive for the patient to use the ICPS network of surgeons, because they're essentially not using their day-to-day funds and their savings accounts to fund that rehab and physio, because it's such an intrinsic part of the process of a joint replacement.
Sorry, and the threats, are they to you or are they to the people who want to join you? And have they gone as far as taking you to court? I mean, what are these threats?
Well, the Orthopedic Association and the Anesthetic Society have written to their members, warning them not to join the network on the grounds that it's in breach of this Regulation 7.4. And they did notify us towards the end of last year that they would be reporting us to the Health Professions Council, and they notified MedScheme that they'd be doing that as well. That's the Anesthetic Society.
Have you come to the end of your presentation?
Yes.
Thank you.
Yes, I'd love to. Dr. Rex and Dr. Springfield, actually, I think I'm not going to ask you details on your presentation, because I'm really assured, I'm sure, that initiatives like these can be very, very important in cutting costs and improving quality. And there's abundance of evidence, I think, around the world where initiatives like this have happened and work. We had a presentation a couple of weeks ago where the Aravind, I'm not sure whether I pronounced the word correctly, it's the organization in India, the hospital organization that does cataract surgeries for 10%, I think, of the normal fees, and that's much better than the rest of the country, where the innovation even went further in the sense that they reorganized also geographically the spread out of the hospital and the organization of the hospital itself. So I'm convinced. I'm not going to ask you for details. I'm convinced this is happening, and what's the interest of the inquiry, of course, is not so much to delve very deep into individual initiatives, but to understand why initiatives like this encounter resistance like you do. And you gave us a number of factors, particularly relating to medical specialists, isn't it? You have given us the fact that the HPCSA rules, both on employment of doctors and not getting decent doctors employed by the organizations they work for, and on global fees, poses a barrier to entry, actually, of your initiative. And one of the subjects of the inquiry is to really analyze barriers to entry of initiatives like yours. One of the 6 areas we work in. I made some notes, and maybe you can bear with me. I made some notes on possible other barriers in relation maybe to doctors, and I'll come back later to barriers that might be related to hospital schemes or regulation. So what I noted is, first of all, let's get rid of that global billing. The HCPS has a role in that, and the idea that sharing fees automatically poses a threat to the integrity of the medical specialist, and I'm convinced that this should be clarified. The lack of ARMs, especially performance-based type of payment models, you alluded to that fact, I think, is a could be seen as a barrier to entry for your initiative, isn't it? I'll get back to that later. The second factor is that we touched upon the fact that there is no quality measurement, be it PROMS or clinical outcome measurement, in South Africa. That happens in the UK, isn't it? It's more pronounced in the UK or in Holland, in Germany, in Sweden.
The UK, yes, I can state with certainty, and my guess is it's probably used widely in Europe as well, but I'm not an authority on that. So.
Yeah, I was personally responsible to introduce in the Netherlands the set-on knee and hip replacement, I think 8 years ago. We started doing that, and it is not easy, but it's been done, and it's now quite mature, I think. You know, you talked about the HPCSA rules, but how important is that factor that in South Africa, in terms of getting entry and to prove that your system really works and cuts down costs and improves quality? How important is the factor that we do not have PROMS or other measurement of quality in this system in South Africa on the full scale of the South African healthcare system? That's on quality, but I think that also relates to gathering relevant data in general, isn't it? Can you?
Look, I'm not an authority on that question, but my impression, my view is that there is a terrible asymmetry of information between patients and professionals internationally. And in South Africa, we have the split between the patient and the funder. So there's a third-party payer system, which is what you've obviously been grappling with in much more detail than me. The funder generally is able to transfer the costs back onto the member by just increasing the medical aid membership fees. And I think it's really just consumer pressure that is a bit of a blunt tool onto the third-party payer, and it's complicated by the fact that the provider's another party. For your average patient or member to sort out that in this highly technical environment, I think is very difficult. The question that you're asking, why is the value proposition not there? Why are there no, when you buy a McDonald's burger, you know what you're going to pay and you know what you're going to get, whether it's in London, Amsterdam, or Johannesburg. When you get a joint replacement, there's no real promise about what you're going to get. And really the quality control is the vital missing link. The outcomes measures are an important missing element in that. The reason they're not there, I think, is what you've touched on. It's technically complex. You've seen how difficult it is, how much there is that just in this one procedure, which is a relatively straightforward procedure, with two hip and knee replacements. We've brought a lot of expertise to bear on it, and we've had tremendous support from, funders in that regard. And it's still been difficult to develop these quality measures. The only reason we came up with them was because we developed them in the UK for the ISTC program for the NHS, and that was incredibly intensely funded by that government. So there was a lot of resources to develop them just for hips and knees, and then we kind of imported it. So there was an opportunity to leverage off that experience that wasn't really funded in South Africa.
I was quite intensely involved in the Netherlands in developing these standards, but these standards actually, in a lot of countries in the world now, become standard as well. These standards for quality measurement become standards as well, and it's, for the experts, it is really a subject they can spend a day or 2 days on discussing. But for the consumer or for the hospitals or schemes, the outcome of these 8 or 9 or 10 indicators that you need to really measure what is going on. It's quite simple. Your length of stay indicator is quite simple, isn't it? It's clear, and also the complications that you encounter in your procedures. That's quite simple. even for me, I'm not a doctor, but I understand that's a real quality indicator. And of course, there's more. But how can you compare the fact that there's no measurement of quality here in South Africa and not being exposed in that way also to the general public of results? Does it differ with what you encountered in the UK, and did that help you introduce innovative ideas in the UK versus what you encounter here in South Africa?
Relatively speaking, there's a shortage of specialists in South Africa compared to the population size versus the UK. So it's difficult. I mean, a lot of the funders are monitoring quality in the background, but for a large funder to make that, to take initiative around that would mean excluding certain clinicians from their membership. And some of the funders are too big, or the exclusion would mean that they don't have a national footprint anymore to offer their members. So I think that is a big structural problem, is that the relative shortage of specialists in South Africa is a problem. And I think it does make it difficult for the funders to take up that issue. So the other structural issue, which we've certainly found has been a problem, is that it's difficult for the larger funders. The bigger the funder, the more difficult it is to direct their membership to a network, say, of 45 surgeons like ours. They're scared to do that. They get resistance. The brokers selling their products, I imagine, are concerned about limiting the offering of joint replacements to 45 surgeons nationally. There'll be resistance from a marketing point of view, potentially. You can imagine that would be a problem for a larger funder. For a small closed fund, where we seem to be growing more rapidly, it's much easier. And what happens then is we often start at the opposite direction. We ask them, where are the operations currently being done? And they're often done in 3 or 4 centers around the country, sometimes only 2. If a company only has a factory in Port Elizabeth and another one in Pretoria, then there's only really 2 centers. And we go and seek out the surgeons in those areas and invite them to join the network and adopt the pathway. So, you can often do it in reverse, whereas a big open national plan scheme with membership nationally, it's a little bit more, it's a big step for them to take, to direct members.
Thank you. That is clear to me. Good example also of the scarcity of doctors that might prohibit making results public by medical schemes or otherwise. Resistance and the degree of the sort of the cultural factor with doctors doesn't help. The factor that doctors like to keep their autonomy. They want to keep their freedom to choose whatever. That's an international phenomenon. It's not South African. It's everywhere. You have it in Holland and Sweden, everywhere. In the UK, you must have encountered it as well. You mentioned the hip and knee replacement, the prosthesis, and centralizing buying these prostheses could also lower, of course, dramatically the cost of these prostheses. We have been dealing with that. That also, of course, limits the degrees of freedom of the people that otherwise would buy these artificial knees and hips. Is there any? Can you tell us a bit more what the resistance was? I could imagine there's a link between the doctor or the hospital to a certain provider of these prostheses that you then cut off. Is there commercial interest involved here?
Look, what we're trying to do to lower the cost of joint replacement in South Africa and get it more in line with the cost that, say, the NHS is paying, or that can be achieved in a country like India, obviously meets resistance, particularly from prosthesis suppliers. Now, I must say that there is a distinction. I mean, several of them have been forward-thinking and have supported us from the word go and continue to support us. and are thinking along the same lines of making it more affordable in the South African private healthcare context. And I mean, I can mention Smith & Nephew stands out in that regard, and Johnson & Johnson have also come to the party. And then a lot of the smaller prosthesis suppliers who are trying to grow their market share are also pretty supportive and are coming to the party. So competition has in fact helped in the background to bring the cost of the prosthesis more in line with the international costs. But there have been threats. There have been approaches to these companies by orthopedic surgeons who are unhappy with what we're doing, and there have been threats to withdraw supply. And one of the suppliers, the major suppliers, is no longer prepared to supply us because of this controversy around the global billing and fee sharing. And they've accused us of operating in an unethical fashion, and for that reason, their international governance and their values as an international company prohibit them from supplying us. We were never engaged, we were never given a hearing, we were never asked to explain our model and defend ourselves. They've refused to supply us and invoice us, and now we have to work through a hospital, which does put at risk the cost, our leverage over the costs, and makes it more difficult for us to bring the cost of that prosthesis down. Why it's important is that some of the surgeons have only been trained to use a particular prosthesis and their instruments, so they're kind of captive. They can only use that prosthesis, and so there's a problem there too.
The surgeon goes so far as to set up the supplier against you. Is there commercial interest of these? Is there a commercial interest of these surgeons in respect of the supply of a particular brand of these knees and hips?
Not to my knowledge, no. I can't answer. I don't know the reason.
Why would surgeons then go so far as to try to withhold particular knees and hips from the supply to you?
Look, I don't know the surgeons who've done it. I was just told that a surgeon had complained to the one supplier, and so I really don't know the detail. I got the sense that it was more a concern that we were somehow in breach of these ethical guidelines, and I guess it was. There's a serious concern from some surgeons around professional autonomy and independence, which they feel is important to protect. So there are a lot of issues ranging from philosophical down to practical. I don't think it's just a crass commercial sort of interest. I think there are complex issues that everyone's grappling with.
Dr. Rex, what you have given us here is you've told us that so far as you are concerned, the concern is that the global fee is a breach of the ethical business practice policy of the Health Professions Council of South Africa. That's the reason that you've given to us. Is that right?
Just the reason for what?
The threat that you are facing is that there is a concern that from the society that the global fees are a breach of the ethical business practice policy of the Health Professions Council. That's the concern that's been articulated. Is that right?
Yes.
Is there any other reason that has been articulated to you apart from this?
There's another small rule, 4.16 of the Business Ethics Practice Guidelines, which deals with a similar set of issues. But those are the only two reasons that have been forthcoming.
We've not had any comeback from the clinical aspects of the pathway, the clinical guidelines or the clinical suggestions of how these patients should be measured. We've tried to engage with the various societies and the members, and it is accepted that the pathway is sound, that it is evidence-based, that it's based on best practice. So we've had no comeback from a clinical point of view as to the pathway. It's all just been around that ethical fee-sharing issue.
So the interest is not in the clinical outcomes, not in cutting costs, it's in protecting the position. Two more. On fragmentation, you gave us a very good example of what fragmentation of healthcare and the fact that the ethical rules also prevent doctors to be employed by a hospital, and where then fragmentation comes in of these particular isolated islands on the pathway that do not sort of adhere to the most logical structure in the pathway to get the best or the optimal cost and quality. And you gave the example of the I'm really unable to pronounce the name. Your profession, Dr. Springfield. So the lady that is doing the pre-op and the anesthesia at the same time, and not and gets paid for both the assessment, so the pre-op assessment, and for doing the anesthesia in the same, you know, what is it, quarter of an hour that he or she sees the patient. And you told us that this should be done a couple of weeks before, and then to do the preparation of the patient the proper way, and that sets in motion all these costs and quality improvements. Is there any other way that you can, because I noted this example, I'll thoroughly note it for the rest of the inquiry, because it's a good example, and we of course have heard of this of several doctors. Other doctors just deny, so HPCSA just denies. There's no evidence that this is going to help you in cutting down costs or improving quality. Any other examples that you have of where fragmentation causes cost that could be avoided and you know, causes quality to be not as good as it could be? Is there anything that springs to your mind?
So we are collecting data on all the surgeons that are part of the network, and we share the data with them, the outcomes data, on an annual basis as a minimum. Their results versus the average, anonymized. So their results versus the average of the rest of the group. And that is a form of getting the profession together. Even just getting the surgeons together makes a big difference, because then we've seen improvements. When the surgeons see this, they are professionals and they want to improve and they make improvements. So just that simple act produces quite dramatic results, in fact. And to my mind, it's an example of breaking down the total isolation of the private practitioner as a general rule in the private sector in South Africa.
Question is, we have talked remarkably little about hospitals in your presentation, during your presentation. What is the role that hospitals play? Because I'd imagine they also could be interested in cutting back on costs. Also, their costs are involved in the procedure, I think, because that puts them in a more favored position in their negotiations with schemes, etc. So, what is it? Can you tell us a bit more? What is the role of hospitals, or is there a lacking role of hospitals in making innovations, process innovations like yours, a success in South Africa?
Look, the hospitals have been quite supportive of the initiative and are not, they're quite keen to look at ways of driving down the costs of items, and as a rule, they are participating and supportive. So one of the changes we've got is that there's a little bit of concern around, for example, the quality of nursing after hours in some hospitals in more remote areas, because they don't have enough full-time nurses, so they can only use agency nurses, or in even some of the bigger cities, they can only use agency nurses. So they will then make a special effort to put a full-time nurse with the relevant qualifications on duty for our patients post-operatively if they're in the normal ward. So, you know, there has been an engagement by the hospitals, and they are working with us. Yeah.
Thank you very much for your answers. Judge.
Thank you, Dr. Rex and Dr. Springfield, for a very interesting presentation. I'm just going to continue from where my colleague left off, because my interest was really on how you work and the relationships you have with different stakeholders. So I just want to start with, you talked a lot about your, that you have a national footprint of surgeons, and the challenges you face with establishing relationships or getting anesthetists into your network. But the other people you have a relationship with is with physiotherapists. So in your page 1 on your introduction as part of your written submission, you say part of the global fee includes your surgeon, covers the surgeon, anesthetist, physiotherapy, hospital care, consumables, as well as the management fee. So what I'd like to know is, do physiotherapists have to be part of the network? How does it work? Because I think part of your intervention, as my colleague mentioned, is the innovation around coordinating care that's otherwise uncoordinated. So I'd really like to understand how you coordinate the care and what relationships you have with these different entities.
Right, so when we get an application from a surgeon to join the network, they go through an induction process, and it includes the induction of their entire team. So then our team visits the site, and we meet with the anaesthetist, the surgeon, the administration of the hospital, and the physio. And we take them through the guidelines and the implications. We meet with them as a group and individually. We often have to do commercial negotiations at the same time around the tariffs that we're charging. Generally speaking, the physios and the anaesthetists come along as part of the surgeon's team. So we'll be using the physio that the surgeon normally uses and anaesthetist that the surgeon normally uses. And we'll work with them if they're willing to participate in this process, which amounts to them being measured in terms of their outcomes. I mean, it is a threatening prospect for at face value. And so there is quite an intensive engagement that takes place. And that's what essentially is what our role is.
So would the physios then be part of the network as well? Are they formally part of the network?
We don't formally contract with them, although we negotiate tariffs with them, and essentially there is no contract with the physios.
On page 4 of your written submission, you have a section there you've titled relationships, and you talk about that the major 3 hospitals as well as independent hospitals participate with your group. So what is then that relationship? They participate in terms of the surgeons that work with them, or they are participating as hospitals?
We contract formally. We have a contract with all 3 major hospital groups and the various independents that are part of the network. And essentially it boils down to a tariff that we negotiate with them. and some standards of care that we require, particularly in that post-op period in the normal ward. As well as the nurses play a role in mobilizing the patients and keeping an eye on the patient mobilization and support the physio in the mobilization. And there's a bit of training of the nurses that takes place around that.
So you don't only have contracts with funders, you contract with both funders and hospitals.
Yeah, essentially the hospital contract revolves around the tariff that we negotiate with them, because they're being paid on a fee-for-service basis as well at this point in time. So we negotiate tariffs with them, and we negotiate the commercial aspects, like the time that we pay them after the operation. So it's really there is a commercial sort of contract with the hospital.
And I note that you do have written here your sensitivity around the commercial part, so not going to ask about that. But what I do want to understand is that then in that global fee, what you're including is your negotiated tariff with the hospital, the global fee that you're negotiating with the administrator.
Yes, so the global fee covers the hospital bill, the prosthesis, the surgeon's fee, the anesthetist fee, and the physio. There's really no charge for the patient. The patient doesn't have to pay any co-payment if they have a hip replacement done in our environment.
Sorry, let me just say, so we pay on invoice from the hospital, whatever amount they invoice us for all the consumables used or the length of stay, we pay that account fully. The only negotiation is around the theatre tariff and the daily rate, daily ward tariff. Is that it?
Yes.
That gets negotiated around.
And that is on a fee for service. So the hospitals, the physio, and the consumables are on a fee for service. It's only the surgeon and the anesthetist that are on an ARM, and you combine all of that to have a global fee.
Yes, but because of the optimization and the predictability that flows from the optimization of the patient, really we're having quite a predictable theatre time and length of stay and level of care. So the hospital bill is also much more standardized in effect because of the clinical management that's taking place in the background. So there's no real need to negotiate a fixed fee from the hospital. We couldn't do that up front because we didn't have the data. And they wouldn't believe how low we could get the costs by reducing the level of care and the length of stay. So at this point, one of the steps we'll move to is a fixed fee, because now there's enough work coming through and we're more confident of our data, and we can then, we're in a position now where we can move to that level where we'll get a fixed fee from the hospital, and it's certainly one of our objectives and one of the key strategies going forward. As it turns out, it's not that important anymore because we're getting a very consistent result.
And so what's your national footprint then for hospitals who've signed up?
We probably got, I don't know the exact number, but it's probably about 30 hospitals participating, definitely there's one in each province and in all the major metropolitan areas. So we've got Polokwane, Rustenburg, Nelspruit, Joburg, Germiston, Midrand, Pretoria, Bloemfontein, Durban, Pietermaritzburg, PE, East London, George, Cape Town, several, the North Coast. It's a proper national footprint of hospitals across the three groups and the independents.
My last question on this part is, what I just lost my line of thought, sorry. What's your relationship with the day hospitals? Do you have any?
Joint replacements are being done as 23-hour admission cases in the United States. Currently, there's a growing example of it. But they're not in South Africa. You can see our stay is still, above 3 days. We can get it down at the beginning of the year. When new surgeons join the group, it tends to go out the length of stay, and then by the end of the year, it comes back down to about 3 days. We've been as low as 2.9 days at some sites. So it's not a day hospital procedure at this point.
But it can be in other contexts.
It's not really widely done. It's kind of experimental at this stage in America and in parts of Europe. It's not widely practiced yet.
Then my last question is with the evidence base. Much has been said in the inquiry about funders using different formularies and clinicians contesting that. So I've heard Dr. Springfield replying to one of the questions, saying there hasn't been any sort of contestation for the clinical evidence of your innovation. However, during the presentation, you said that you do encounter instances where people have not complied with your guidelines, and if they haven't, then you ask them to present evidence of why they haven't. So I just wanted to know, going forward, whether you do think that there could potentially be reasonable challenges with different formularies, given that you explained that the guidelines from the US, from Australia, Denmark. So I just wanted to know, given that there are instances where people do tend to use different guidelines, how you foresee resolving that?
I think we only essentially would become involved if that particular patient or that process becomes outlier. So if an anaesthetist consistently does something that's not recommended in our guideline, like I said, we don't dictate to them. This is just, we've looked at the evidence and this is a guideline. It's a suggestion. So if there is someone who feels that they would like to do something in a particular way, we're measuring that, and then we measure it according to the outcomes that everybody else gets measured in. And if the outcomes are the same, we don't interfere, because it clearly is then working. But if they become outliers, that's detrimental to the patient, then we would step in and say, please, we've noticed that this is happening. Why is it? Provide us evidence as to why you think that your system works, because this is how you are comparing to everybody else and to international standards.
But isn't it possible also that the departure from the guidelines might have cost implications, and so who reimburses the difference?
We would absorb the difference in most instances because it's not that dramatic. If there's a dramatic departure from the pathway, there is the opportunity to carve out the case and revert to a fee-for-service reimbursement for that particular case. And that's negotiated between ourselves, the clinician, and the medical aid on a case-by-case basis. There's so few in that category that it's actually quite manageable.
Thank you.
The presentations from the various funders have told us that they're always looking for value, which I interpret to mean quality and cost. Why aren't they beating a path to your door?
I mean, I think that it's best to ask them that question, but my guess is that it's difficult for the larger ones to limit services to a network, even though I think that the tide is turning and the evidence is now so strong for centers of excellence, which effectively is what we're creating around joint replacement. The literature is now, there's no controversy in the literature. Centers of excellence is the way to go, ranging from trauma, which is not planned, all the way through to planned elective surgery and various other medical sort of interventions. So centers of excellence, really, common sense tells you you can't really disagree with that. And I think it's a step that the industry in South Africa is going to have to take. But I think there are massive logistical, marketing, and practical challenges to get to that. I don't think they should be underestimated, but I think it is an opportunity going forward for the healthcare sector, government and private in South Africa. Centers of excellence, is the way to go.
Have you approached funders with your initiative? And if so, what answer have you received from them?
We approach funders ceaselessly and have for the last 5 years. Initially, the resistance was from the funders. We were pushing on an open door when it came to the surgeons and the anaesthetists and the physios and the hospitals. They were all keen to do this. But there was no uptake from the funders initially. And it was around directing members, even just at a practical level. It's quite a complex, difficult thing. Now, a member's not aware that there's a preferred provider or designated service provider network.
But what did the funders tell you in response to your approach to them?
They raised the problem of limiting their members to a prescribed limited network. As that was the repeated refrain from all the administrators and all the major funders covering the majority of lives. The one that took the first step was Bonitas and MedScheme, the first substantial one. The very first uptake was Transmed, who are administered by Momentum. And they did it because they were under so much pressure. And then MediHelp, who were also under pressure. In fact, their members had taken them to court around the lack of provision of hip and knee replacements in the private sector. So they were in a difficult situation. So those two adopted us first. And they gave us the ability to now take it to the larger administrators and funds and say, look, it's working. And to be fair, Bonitas, who you're going to hear from next, were enthusiastic. They took it up enthusiastically and very successfully, and then they expanded it to all their members this year, and then we've had several other funds in the MedScheme stable, as well as a lot of interest from the Momentum stable. Discovery have approached us recently, and I guess the one other point just to the difficulty we've had is with GEMS, interestingly enough, who we thought we would have a good fit with, but we've just had we've had no ability to access them. I just haven't been able to get a meeting with anyone who can make a decision around this.
Are hip and knee replacements part of PMBs?
No, not planned elective. Only the hip fractures, which are emergencies.
I've completely forgotten my last question. Oh, yes. So what I wanted to ask you is, I take your point about the HPCSA ethical rules, and it seems that this is something people are actively using. In relation to new innovation in the market, how much do you think that there are, besides this one, real barriers? And how much is it that innovation takes time and you've got to claw your way in, and that any innovation in any market has to find a little niche, prove itself, and then suddenly it takes off. How much is your experience an expression of that, rather than the ethical rule aside, a real barrier to entry?
I'm not sure, but I do think that the skill required to develop these things is quite high and quite limited, internationally as well as, but especially in South Africa, both on the funder side and the provision side. So that's another factor. You know, we just don't have the skill to kind of spread around. We've been dying to get something going in a range of other elective procedures, and one of the things that is a massive opportunity is maternity, where the caesarean section rate in the private sector in South Africa is anywhere between 70 and 88%, I believe, in Johannesburg currently, which is inexplicable and unique to the South African private healthcare environment, where the target in the UK, for example, is 20 to 30% for a range of solid scientific and reasons. That is definitely to do with the pathway, because single-person practices for obstetricians, by definition, means that you cannot deliver babies 24 hours a day, 365 days a year. The mother who's come to see you wants to be delivered by you as the obstetrician. Obstetricians aren't practicing in teams in South Africa. They're not supported by midwives, as would be a standard model in most healthcare operating systems. So we just don't have the model in the pathway to address that high caesarean section rate. And I think that would require a massive amount of skill to get that going and get that up and running, as well as potentially capital to set up your maternity hospitals that address that sort of thing. So, and at the moment, let's face it, everyone's making enough profit out of the current caesarean section model. So I guess it's only the funders that are pulling their hair out over that stat. And they don't really have the capacity, the clinical skill and the management expertise and the ability to organize clinicians who are in short supply and who can resist change. So that is essentially the big ticket headline items that make change difficult.
So one other question is, do you do anything? So I understand your point of entry is with the doctors first, and then once you've got your network, you then go to the funders. But is there any experience in this type of approach to also educate the health service user? So, for example, if we take the caesarean section example, best practice tells us, and evidence exists, which I think is pretty indisputable, that caesarean sections carry huge risks, whereas natural births carry lower risks. So it means that health service users are choosing a procedure that is more dangerous. And similarly, if your model is as good as you describe, then your model is better. And if I'm a consumer of healthcare, how do I know that something like that exists? When I go to my doctor, I say, oh, well, I need hip replacement, or I'm going to have a baby. I don't want a caesarean section, and I want to do this ICPS. I want to go to ICPS. Is there space, opportunity, any experience anywhere where these kinds of approaches have been marketed at the consumer level rather than at the provider level?
Life Healthcare has a midwife-based maternity unit, Genesis in Johannesburg, and they market that. The uptake is not that fantastic. I mean, anecdotally, the obstetricians that I've dealt with over the last 20 years say that they get tremendous pressure from mothers to have a caesarean section. It's reached that point where expectant mothers are putting pressure on the obstetrician to deliver via caesarean section for reasons that I can't comment on. I mean, that's a topic for a lifetime of research, I guess. So There are a lot of complex dynamics in that marketplace that make it very challenging.
Is there any reason why you haven't taken your model to the consumer?
The cost of advertising, you're talking about the hip and knee replacement model. Firstly, it's a small part of the population that need them, generally speaking, 60-plus age group. The cost of targeting them with advertising, and then within that, it's a very small percentage that need a hip replacement in any particular period. So, you really can't, for us as a small startup company, we can't carry that sort of advertising cost. This can't be done.
And then my last question is, you've presented us with a lot of data on comparisons, and as I've asked previous people, has any of this, the methodology isn't here, so we can't comment on the integrity of the research, we just have the summary results. Sometimes actually, I suppose I forgot to say this to the people, it can always be included as an annex, which is useful for us so that we can assess the methods. But have you and are you planning to publish this in peer-reviewed literature? Have you published it in peer-reviewed literature? And I suppose if you haven't, what I'm encouraging you to do is to do that.
So when we did our proof of concept a few years ago, 3 or 4 years back, we did a pilot of 50 cases down in one private hospital in Cape Town. And from that, we got 2 orthopedic fellows to do a paper on standardized care pathway in a private health setting, South African private health setting. And that is with the orthopedic journal currently being reviewed for publication. But certainly we're very keen, because these results are substantial, and we're very keen to publish, and we have a program of publishing in peer-reviewed journals going forward. Our data is not exclusively ours, so we have data that we collect, and it's open to be audited. And then there's also independent data that the funders are getting, because these patients are their patients. So we're able to sit down and compare what we have with what they have. And we do sit down every 6 months and every year where we have a look at the data together, and we compare what they've got, and we share what we have with them.
Thank you for the presentation. I just want to follow up on some of the questions that have come up, and specifically starting with the issue of pre-op assessment. I obviously had Judge taking interest in asking about that, but I think I just want to highlight the value of your presentation from that angle. On the 24th of Feb, we had the Society of Anesthetists, and we asked them, anesthesiologists, we asked them this direct question. It was on the broader question was, do funding rules actually subvert clinical practice as it should be done in private practice? And I was surprised that SASA did not raise it in their presentation, and when asked directly, they did not come across as really being concerned. So the whole point about this, you guys planning 4 to 2 weeks before, and the denial that these assessments happen on the red line was just a bit astounding. So it's very good to see a very clear, what can I say, maybe evidence or rather support that this is what should be happening. So on a broader scale, I'm saying beyond this is another core principle which I believe the panel should look at, that structurally there are areas of concern where the private sector is inferior to public service, because this, in public service, no one goes for elective surgery without having pre-op assessment done. So I find a lot of interest and value in your presentation based on sort of that. But one of the other issues, I don't know what this is doing. But in terms of the pre-op assessments, what do you do about the 13% who are not assessed by anesthesiologists, specifically regarding the airway assessment?
So these patients that do not have access to an anesthetic pre-op clinic 2 to 4 weeks beforehand, so they are the ones that come from their general practitioners or get seen, a vast majority get seen by the physicians. There are some physicians who assess the airway, but then that's what the anaesthetist would do another assessment on the day of surgery, looking at the airway. So that is inherent in their definition of a pre-op assessment, is that on the day of surgery, they look at the risks that that patient immediately would present to the kind of anesthetic that they would have done. So if they do an assessment and they see that, oh, the patient has got a difficult airway, well, then they'll quickly have to rechange the plan and do possibly a spinal anesthetic. That is currently what's happening. That's why we would prefer that our patients get seen by the anaesthetist, who not only will they be optimized, but then from an anesthetic point of view, specifically looking at the anesthetic risk, that anaesthetist can in a timely fashion then assess the specific anesthetic risk that that patient poses on the kind of anesthetic that the anaesthetist was going to give.
Just add to that. The whole situation, the practice around pre-assessment and optimization is quite complex, because most surgeons these days would refer their patients to a physician. And many of those would in fact be optimized, but many might not be optimized. And really no one knows what the practice is out there, which is why you need a standard care pathway to say, look, this is it, and we're monitoring it and we're measuring it. So I don't want you to get the idea that it's just not happening out there, but we are seeing that because of our various interventions, there's a dramatic difference in outcomes, and we feel that intrinsically that this is probably one of the explanations is the pre-assessment preparation. But it's a little bit, we can't be sure what the practice is out there by way of optimization, because the patients are being assessed by a physician who isn't the perfect person. It should really be an anesthetic pre-assessment to establish the anesthetic risk and to optimize for that, and to make sure the patient is optimized. And we just don't know what the practice is outside of our network really, but we are seeing that by insisting on that as one element of many, by the way, because there is the physio element preparation, there's the psychological preparation of the patient, and then there's the anesthetic technique that's used, which is essentially to aim towards a physiological type of anesthesia and various types of other elements, which we won't go into too much detail, but which are all evidence-based and standardized. They all add up to this better outcome. Exactly how we attribute it, we don't know.
Does it mean all of the elements in your program, are they all scalable? I'm asking specifically, at this stage you said all of the pre-op cases get seen by a review committee of sorts. Is this practical when you get bigger?
Look, from a surgical point of view, our surgeons currently have the capacity to do all the joint replacements in the country. If they were just doing joint replacements, they could potentially, with a little bit of extra growth, potentially do all of it. The anesthetic side is more complicated because we clearly have a shortage of specialist anaesthetists. Large parts of the country don't have a specialist anaesthetist. They only have a GP anesthetic service. There's no reason why the standardized pathway can't be used with a GP anaesthetist running it with certain levels of skill and experience. They'd have to be supported and monitored in various ways. But I think there are challenges around anaesthetic capacity in the country. I think that's undeniable. But I do think it's possible to scale this model in different ways. And that's exactly what a company like ours is necessary for, where you've got high-level clinical expertise that's liaising between the various parties and doing the coordination and thinking and service development and measurement and all that sort of thing, which is a gap in the market currently.
Now, beyond, I'm obviously taking you out of your scope now, but beyond the joints that you're dealing with, what other procedures do you think are as amenable to your way of working?
I think Dr. Springfield should answer it, but essentially all cold elective planned surgery is theoretically amenable to it. All of it is routine, is planned and can be potentially standardized. There's no reason why it can't be. Even a non-elective procedure like maternity opens itself up, lends itself. But everything from bypass surgery to stenting to spinal surgery, cholecystectomies, there are standards that are now evidence-based and that are published widely and practiced widely in advanced first world economies, and there's no reason why we can't gradually start introducing those.
Now on facilities, how many different facilities have you used roughly, if you know offhand? Look,
it's about 30. It changes. The reason I've got a hesitation is that we're adding sites all the time, and I haven't actually done that. We can get you that number.
From what you've said in answering some of my colleagues' questions, that there is no specific preferred facility provider. It's basically anyone that you deem a good facility.
Look, there's a big price differential between the different hospital groups. But my sense is that is more a commercial competition thing at the moment, where I think one of the hospital groups is developing a similar network to ours and is pushing our price up a bit. They've got the highest price for us, and it just makes me want, you can only guess at the reasons, potentially.
Do you make them compete? Do you make them compete for your business?
No, because we approach surgeons or are approached by surgeons. And then we just, wherever those surgeons are operating, we go and develop the model at that site. Our leverage over the negotiations is the more cases, the more medical aids that contract with us, and the more cases we get, the more we'll be able to influence and direct and divert patients. So we have developed a model where the one hospital group is now no longer affordable for our low-end Transmed and MediHealth patients, where we have a much tighter model for reasons of those medical aids. And so it's restricted now to 10 sites, and it excludes one hospital group in particular.
So it's almost a network within a network, really. It's turning out to be.
Yes.
Now, one of the key features now in taking your model to its ultimate, best practice, at some point you need to start considering the whole issue of centers of excellence. And at this point, you're counting many hospitals, and you've just explained how you choose them. But is the concept of center of excellence a consideration going forward? And if it is, how do you plan to balance the issue of managing that the hospital doesn't have too far to go, but also sticking to the issue of dealing only with the hospitals that provide you best service.
In the UK was that 1 hour travel time for a hip or knee replacement. And that's in a very advanced economy with massive resources for healthcare. I mean, the spend on the NHS in pound terms is almost the same as our gross national product, and we've got roughly similar population sizes. So to give you an idea, they spend a lot of money on healthcare. I think generally patients themselves are probably wary of having a major procedure like a joint replacement in a small, far-flung town. They're probably worried about the standards. And anyway, it's generally not offered in smaller, remote areas. So I think as a rule, to have something in each province is a good starting point. And then in the more sparsely populated provinces like the Northern Cape, you really are struggling a little bit. You need something in Kimberley, and probably your next one is Uppington, and that's probably about it. So the patients are going to travel there regardless. And anyway, those are the only two sites that are probably offering joint replacements in any event. So we're not living in an ideal world in the South African context, and we don't have the ideal distribution, but for that matter, no services really. And the more complex the service, the less widely distributed it is. I don't know if that helps.
No, that's fine. Obviously, we understand that you're also still starting, so you may not have all the answers yet. But one of the... You've already started on this question when really on the issue of networks. Most of it, what we're seeing in this country, it's about based on hospitals, on the facilities. But the other way can be based on clinicians. And I'm just thinking here, I think the ophthalmology management group is probably one that at least at some point had a deal where it struck the deal with funders and took care of the rest. Do you see a situation where your deal is really with the practitioners and they are the ones who decide where they're going to, meaning they negotiate with the facility? Have you thought that far? Is it something that in the long run you should look at?
My sense is that practitioners don't have the time to enter into these complex negotiations with hospitals, with suppliers, and with funders. And that there's a need for a group like ours to do that, or for the hospital groups to potentially take the initiative and set up networks within their hospitals. I mean, that's another route forward. I don't think the clinicians, unless they give up their clinical practice by and large, like I have, that can do it. I think there are constraints. And then there's another problem, which is that because of the competition between clinicians, it's difficult for them to work together and organize their colleagues into a group. So it's better for an outsider like myself, or like a non-threatening company to take this initiative. It's no coincidence that a small company like ours has got this far, because I think clinicians are traditionally a bit skeptical. They don't want to be employees. They want to be self-employed. They don't want to end up as employees of hospital groups or medical aids. So they quite like the fact that we're essentially a collegial group of clinicians, and we're working on their behalf. And I think that's some of the secret of our success.
Well, the counter would be they do have management groups. I quoted the Ophthalmological Society, Ophthalmological Management Group. You've got the orthopedics, you've got the physicians. So what I'm just saying is there are means of getting around. Just because it's a clinicians group does not mean that it's the guy who must do theater. They do have management companies. So it's in that context that I was asking it. Now, Prof. Von asked about barriers, but I just want to get into barriers from a different perspective, and actually barriers that are caused by you. Now, I'm not suggesting that these are not necessarily desirable. There's a good explanation for this, but in terms of your prosthesis, there is a criteria to qualify. You have to have been, you must be listed, I don't know, internationally on so many lists, you said. Is that going to be a problem in time, in terms of new entrants, in terms of new suppliers coming in? And also another good reason, you say your physicians must be about 5 years qualified plus others. But what does it mean if the model catches up? Where does the newly qualified orthopedic surgeon in practice go to gain the experience? And the other question related to that, your requirements of orthopedic surgeons in terms of experience, are they also in place for your anesthetist or somebody or all the other players in your team?
Right. The problem of sustainability of the model is something that we have been discussing, and we think that the solution to that is partly in place already. Some of the larger practices have what they call fellowships, where they get funding from the prosthesis suppliers to employ a young orthopedic surgeon who then essentially assists them in theatre and is trained in arthroplasty in the process. That's something we're encouraging, supporting, trying to promote, because even just for the sustainability of our model, there are a group of surgeons who are older who will be retiring in the next 5 to 10 years, and we need a new group to come through. So that's kind of our way of dealing with it, but I think it needs more than us just to be thinking about that, because I do think the capacity to produce arthroplasty surgeons in the government hospitals is diminishing rapidly. That's my sense. The number of joints being done in government hospitals is now probably only, approaching 10% of the total being done in the country. And that's one of the motives for us initiating this, is that we want to actually get this system going in government hospitals, but that also, I think we need to establish ourselves firmly first and then take on that particular challenge. So, and I think NHI presents another opportunity there. So really, we are grappling with it, and we do have some fellows participating with our surgeons and learning by assisting, is the answer to that question. And then the anesthetic qualification, it isn't as stringent. We do require them to be specialists. That's the one requirement. And then there is probably a little bit more hands-on support from us. We employ an in-house anaesthetist with experience who's been involved in the program in the UK, who can then go on site and actually support the anaesthetist. And there's a lot of communication and discussion that goes on between the anaesthetist in the network and our anaesthetist in our office.
Yeah, I suppose the only question that naturally flows from that is that, what? Is it because you do believe that in terms of anesthetics it's not so critical to be as experienced, or you deem them to be immediately ready to hit the road the moment they qualify? You don't have to answer. I'm just saying that was what was in my mind in terms of consistency regarding the minimum criteria to work with you.
Look, the anaesthetist generally has been working with the surgeon for some time. So our criteria for the surgeon is that they're doing a certain number a year and that they have been qualified for at least 5 years. Inevitably, the anaesthetist would have been part of that process. It may be that they use two anaesthetists, so it may be split. But generally speaking, the surgeon's going to be using an anaesthetist who is used to doing joint replacements as well. So it's a little bit less onerous. In any event, we can't we don't want to interfere in that relationship. We'd rather develop the anaesthetist and keep the team together, because there is a quality issue around breaking up teams. So we'd rather keep the team together as much as possible and develop it, and really use the surgeon as the proxy for experience across the whole team.
One of the main disadvantages of global fees is the potential to lose detail and statistics for future protocol management, for future pricing. How do you deal with this in your pilot so far?
Just repeat the question. I didn't get the first part.
Okay, I'm just saying one of the disadvantages of global fees is that you tend to lose detail, both clinical, both detail you need from a pricing perspective. How is there, in terms of how your billing is handled, is it different, or you still bill on a fee-for-service basis for the purpose of maintaining the data?
We get a detailed fee-for-service bill from the hospitals, which includes theatre time by minute, length of stay down to per half day, all the consumables that are being used. We then capture that, essentially the top cost drivers within that whole profile, as well as a few clinical quality indicators like use of opiates and various other things. And we use that as a tremendous source of clinical quality information, interestingly enough. And the medical aid then ends up not getting that. But we have got it, and we are quite happy to share all of our data with the medical aid. Although, in a sense, they're increasingly relying on us to manage that for them.
Necessarily required to see the detail.
So far, that hasn't been an issue in the environment, because we're producing such staggering results for them and we're delivering a saving for them, that it's not really a concern. I think if we started being less successful, they might want to see the detail. But right now, I don't think it's bothering them.
In terms of physicians who are resisting, I use physicians like Americans do. I'm just talking clinicians. Have you come across the oft-quoted example of orthopedic surgeons who supply, them or their families, who supply prostheses to their very patients?
Yes.
Is that a big issue? Is it widespread?
No.
Unless I'm wrong, I haven't heard you say specifically, I did step out, if you have met the HPCSA to discuss this at all, have you?
No, and the reason is that we don't treat patients, so we don't fall under their jurisdiction. The threat to us is to our participating surgeons and anaesthetists who are treating the patient. So in fact, we've written to them. They've written back. We've explained we're not treating the patients, we're not prescribing, we're not operating, and they've gone quiet. And I think the reason is simply that we don't really fit under their jurisdiction. And then the alternative is the Council for Medical Schemes, and they've responded by saying we don't take on enough risk, financial risk, because of the carve-out model and because of the standardization of the process. So they don't feel it's necessary for us to register with them. Their registration is quite onerous, so we're not. So at the moment, there isn't an ideal regulatory environment for an organization like ours, which I believe should be characterized as a true managed care organization, in the sense that we're managing the clinical process, not by restricting access and utilization in the way that the auditors, in the way that sort of actuaries or accountants would do. It's more managing the actual clinical process. It's not envisaged in South African regulation currently.
Well, I was asking from the perspective of lobbying, because a key enabler for widespread use of a model is that global fee rule that is used to block you. It was in that context that I was sort of asking that. But clearly you haven't started that process.
Well, we started it, but it's got nowhere because they don't believe, I don't think we fall under their jurisdiction. So perhaps one of our members needs to take it to them for clarification. Maybe that's the way around it. But whether one of our members would be prepared to do that is unlikely.
You made a passing comment about thinking ICPS and obviously similar organizations need to be recognized through legislation. What form of recognition are you talking about? Other than, of course, I think it's indirect though, the issue of getting enabling the global billing systems, that aside. What sort of recognition do you think should be considered, and how would it further enhance your offering?
I think the correct place for us to be located is as a managed care organization registered with the Council for Medical Schemes. Now, the registration process for that is extremely onerous, financial reporting as well as clinical reporting, and information system standards that a small organization, which is the nature of this, simply don't have. So that is a mountain to climb, and I don't think they envisaged this sort of organization when they drew up those rules and regulations. And I think that could be re-looked at as well, to make registration for groups like OMG and the gastroenterologists in Cape Town and ourselves. I think those are the only three groups. I think the oncologists are another group that are trying to develop pathways and things. We the pioneers and the innovators. I think there's a place to revisit the MCO rules for registration, and I think that would be worth looking at so that it's more straightforward and less onerous in terms of the IT requirements and so on.
Last two questions on the doctor still. The orthopedic surgeon, or actually and the anesthetist as well, in terms of your negotiation, whether the case is 2 hours or a complicated one that's 5 hours, the fee is fixed. It's what you negotiated up front, because you can't always predict if the case will unfold as planned. Is your fee fixed in that sense?
It is fixed in that sense, but a case that complicates to the extent that the theatre takes 5 hours. I don't think we've ever had one, but we have had cases that maybe 3.5 hours or so. The cost at 150 odd rand a minute on average would mean that case ends up being a carve-out. I mean, we would listen to a surgeon. It's a theoretical problem because we haven't really had that problem. But a surgeon who came to us and said, look, this was a nightmare for various reasons. Could we carve it out? We would take that to the medical aid, carve it out, and revert to a fee-for-service. Not that they are paid extra anyway in the fee-for-service model for a long case. The only group that are paid on a time basis is the anaesthetists, because it's not in their control. But the surgeon is paid for that joint replacement, that code. There may be other codes that they would attach to it, but it wouldn't dramatically increase the fee that they're earning just because the case is longer.
My last question now. Do you see an opportunity that coming out of your statistics in terms of safety, in terms of all the other advantages, that it could be a selling point to your physicians to say, we can start showing medical malpractice insurers just how good our outcomes are? Because the malpractice costs are a significant input cost in terms of provision of healthcare. Is that an angle?
Look, last year we did 448 cases spread across probably about 15 sites. Now we've got about 30 sites and we'll probably do about 800 cases. So the number of cases per surgeon is too low for us to be negotiating at that level yet. there's an economy of scale issue, in other words, or there's a scale issue. And when we get to scale, I think it's an obvious opportunity.
Unless, of course, it's at a center of excellence basis, because that's how they get to be the best. It's a fewer specialists doing far more often. Okay, thank you.
Am I correct in assuming that what you have described today is what should be done when treating a patient?
Humble opinion, yes.
So if it is not done, then it suggests that there is a failure of the system.
You know, I think with the advent of the information era, the information is now available. I don't think standardized care pathways have been implemented. You know, they only really started implementing them in the last decade, and really started in a very small way in the UK and in Scandinavia. And we've heard from Dr. van Gent that they started in the Netherlands about 8 years ago. So, you know, we're not that far behind, and I guess it's a process, and I think there's a start being made, you know, across a few disciplines now. So, yeah, there's definitely an opportunity. I prefer to think of it as an opportunity that we can now, you know, follow.
Because what you have described this morning, it just strikes me as being the kind of things that should be done. For example, before you undergo an operation, there has to be the kind of assessment that you have described. I mean, at a bare minimum, that should be done. It should be done a minute before the operation.
Yes, and it is an opportunity that I think the whole health system can start delivering on.
Because otherwise, if it is not done, one of the consequences is that there may be complications which could have been prevented. And these complications would necessitate a return to hospital in circumstances which could have been prevented, and that increases the cost.
Yes.
Who do you work for? Do you work for medical schemes? Do you work for administrators? Do you work for orthopedic surgeons? Who do you work for? Who pays you, in other words?
The medical schemes pay us. But it often feels like we work for the surgeons or for the patient, in fact. Because often, you know, we feel we're representing the patient and we've got the information available to represent them so much better. So there's a complex question. I think ultimately it's probably somewhere between the clinician, the surgeons, and the medical aides that we are positioned and are kind of partnering. Rather than saying who do we work for, I think we're trying to partner all these parties and try and get the thing right. You know?
You can't work for everyone. You have to identify who you work for. But am I correct, though, that your primary concern really is that from the time a patient sees the doctor up to the time when the patient is discharged, goes home, you are there to monitor, to make sure that he or she gets the proper treatment?
Look, the first line of monitoring and the responsibility lies with the treating clinician, where the main contract is between the clinician and the patient. So we're not superseding that role. But overall, in terms of the outcomes, if you step back in the way that we've described, that is what we do.
And the ultimate objectives is perhaps twofold, maybe more, but is to make sure that the patient gets quality treatment at a minimum cost.
Yes, and our role, I guess, is coordination along the pathway and a multidisciplinary pathway that is lacking in general in the system currently.
And this is what ordinarily the medical aid would be concerned about, because medical aid represents the interest of the consumers.
Yes.
Your services are akin to what has been described throughout these hearings as managed care, but from a clinical standpoint.
Yes, and I just must stress that it's clinical management as opposed to utilization management, which is a different interpretation of managed healthcare.
What I'm suggesting to you is clinical care. Is that what it's about?
Yes.
But what you are telling us today is that neither the medical schemes, well, the council or the health professions council is prepared to take responsibility for your organization.
Well, I think at prima facie, we don't fall under the Health Professions Council. And the Council for Medical Schemes, we're not taking enough financial risk, but I think that's probably the right location. Yeah.
What you are really saying is that there is a gap. There is a legislative gap in the sense that, organizations such as yours, which are playing a critical role in terms of ensuring, proper clinical care, cost saving, are not catered for.
The simple answer is yes, but there is a proviso that there is this legislation for the managed care organization, formally, and it is there. But if you go through it, it is not a good fit with the kind of organizations that are innovating at the moment.
Convey to you. So are you saying that it is there, it is catered for?
I think it needs reform.
Is there anything else that you'd like to tell us, which you haven't said so
far? I think in conclusion, we don't want you to be left with the idea that it is all bad practice outside of our network. I think there is some excellent practice going on. And these are just the global views of the averages that transpire. But within the non-networked side, there are fantastic clinicians and practices going on and innovations happening. And I guess the idea is to identify that and build on it going forward.
But if your statistics are anything to go by, that is, you are able to reduce the hospital stay drastically, as you suggest you are able to, then there must be something wrong somewhere.
At a very high level, maybe the one point we haven't mentioned is that, we heard a statistic that 40% of cases done, and this is a reliable source from one of the larger funders, are being done by surgeons who are doing less than 5 joint replacements a year in their books. And that the cost of those cases is double on average. The remaining 60% in their books, where the surgeons are doing more cases. So I just want that's a background that we're probably falling on the side of the 60% who are doing more cases, which helps a lot without any of the coordination. So you can just add that to the picture.
Is there anything else that you'd like to draw to our attention which you haven't raised in the course of the engagement with the members of the panel? Yeah. Okay. Let me make sure that I get the message. your concern is that organizations such as the one that you represent do not have a proper regulatory framework.
Yes.
Thank you for the presentation, and also thank you very much for coming to share with us your idea of how we can save cost, but at the same time ensure that patients receive quality treatment. And thank you for your willingness to stay more than you were required to, because we have overrun the time. Thank you.